what to use and when. I want you guys to feel confident and comfortable in what it is. And remember that there's not always one right thing. You can try one way. Maybe you say, hey, I'm gonna put an cannula on and they still got oxygen saturations of 70, so then you switch up to a non-rebreather. But I want you to know which does what it's for, and how much oxygen it delivers. So remember, when you are breathing in oxygen just like this, the atmospheric oxygen is only like 21%, 21 to 24%. So when we give supplemental oxygen, it gives it at a more concentrated level, and you'll see on the PowerPoint how much more of a concentration. Of course, when you are using oxygen and got it wide open at 15 liters per minute, it's gonna be, you know, closer to 100% of pure oxygen. And then it decreases as each level goes down. I did bring a CO2, like I talked about before, to show you guys how to use it. You guys aren't gonna be able to interpret the waveform, and we won't really get into too much detail of the hows and the whys, but you will be familiar. If someone says, like, for instance, if you're on the truck with me, if there's a respiratory of any kind, I always have CO2 on there. That is my personal favorite tool that we use on the truck because it really tells me a lot. So what we're gonna go over, like I said, is we're gonna identify the appropriate device to use, choose the correct flow rates for it, and assess for desired outcomes, and then we can talk about what to do if it's not the outcome that you're wanting. So non-rebreather, that's this. Moving over. The flow rate for this is 12 to 15. Some people do go with 10, but you really want to make sure that this bag stays blown up the entire time. And I did a little bit more studying about these things so I could really tell you guys the true way instead of my interpretation of what they do. But so what we would use this for is signs and symptoms. If you ever see this SS, that's the abbreviation for signs and symptoms. But hypoxia, it's for severe trauma, profound dyspnea, which is shortness of breath. That's how we abbreviate shortness of breath, SOB. It's not a cuss word, because sometimes I use it as that. And for altered level of consciousness. So the thing to remember about this is they must be spontaneously breathing. So when you go to hook this up, it'll come apart like this. Either side will hook in, and you'll hook this to the tree of the truck. What I always do so it fills up faster. Now this will fill up eventually without you pressing on it because it has this little seal right here. But I always hold it down so that way it fills up faster. And then once that's filled up, you're gonna put it on the patient like this, if you're like a flight attendant. And make sure it's above the ears and adjust this nose thing to where it fits snug on there. So what happens with this is, the reason that they call this a non-rebreather is because they are not breathing back their own oxygen. They're actually breathing the oxygen straight from the cylinder. And these things right here are, so when the patient is breathing out, it seals this. That's what this is for, so that way it's not pushing the air that they breathe out back into the bag. It's just continuously getting new oxygen. And then when they take a deep breath in, this is like a little flutter valve. And so it lifts up, and that's what brings that oxygen in there. So, and the reason that they call it a non-rebreather is because they have these valves on there. So, again, when they breathe out, that comes in, but when they're breathing in, they're not getting the atmospheric oxygen, they're getting just this. So that shuts down. So that's truly what those are for. Any questions on this? So would you give this to somebody who was breathing 4 times a minute? You would? Do you, what's the normal ventilation rate for an adult? 12 to 20. So, would you give it to somebody who's breathing only 4 times?
Yeah,
You would. Why?
because it's more high flow oxygen.
It is, but you also get high flow oxygen if you're bagging them, right? We'll get more into that. So the nasal cannula, this is for those who just need a small amount of supplemental oxygen, or they can't tolerate a mask, and you will find lots of people who cannot tolerate something over their face, especially when they can't breathe. They get all panicky, and so you'll have to either blow by or you can do this. Now, you only want to do it 2 to 6. If you go to a nursing home, inevitably that patient will have an oxygen saturation of 50 and they'll have it on 2 liters, but most of their equipment doesn't really go as high as it needs to. A lot of people use these as a norm because they're on continuous supplemental oxygen. COPD patients, heart failure patients, anyone who has any kind of lung disease uses this. But something, it's a pet peeve of mine that I want to instill in you guys is when you put this nasal cannula on, can you guys see these prongs right here? I mean, you guys have all seen this up close. Make sure the prongs are down, not up. Otherwise, you're just blowing oxygen out and not really up where they need to be. It goes up and it kind of hooks in there. So, I don't know if you can see very well from here. You put it on there and it hooks in that nasal notch, rather than if you were to put it up like this, it's pretty much just blowing out. I thought that I had a C-collar here, but when we do trauma or next time we use the C-collar thing, I will show you on there are 2 little notches that you can hook this to, because if this patient has a C-collar on, you're not going to be able to get to their ears very well. So there's notches on the side that you can hook to it. It's very convenient. Let's see what time we started, but so the oxygen that you're getting from this is only 24 to 44%. So remember, I said 21 is the atmospheric oxygen concentration, so it's really not that much more. We do tend to use this more on chest pain patients. That's protocol. You start oxygen on them. Stroke patients are very good candidates for this because you want to make sure that they're getting oxygen and perfusing as much as they can. You want to save that brain, and you know they say time is brain. We'll run that when it comes to stroke stuff. But so this CO2 nasal cannula. Does anybody remember what the magic numbers are for CO2?
35 to 45.
35 to 45, good. So you can get a baseline. What you do when you first get to them, let's say dude man is short of breath, inevitably they're tripoded over. He's breathing, so if he's wearing his home oxygen, you can switch it off and keep it at the rate that he always keeps it at. But if they don't use supplemental oxygen, I'm sorry, Veronica, you can't see very well over here. But if they don't use supplemental oxygen, get a room air reading, and so you'll put it on them, and they're gonna hate it. This little bubble is annoying. If they don't have any teeth, they're constantly chewing on that bubble, and you have to tell them not to. But this little reservoir is what gauges how much CO2 they're breathing out. And remember, if they're breathing too fast, their CO2 is going to be low. If they're breathing too slow, their CO2 is going to be high. We had a patient the other day who, we got him at 5 in the morning, called out for chest pain, bigger gentleman, and we get there and his CO2 was 78. That's double what it's supposed to be. So, I asked him if, while he was sleeping, if he wears a CPAP. which most people do if you have sleep apnea because you quit breathing so many times, while you're sleeping. Does anybody have a CPAP in here? That's good. I probably should because I snore very loud, but, so what I think what happened is while he was sleeping, he quit breathing so much that he retained all that CO2. And so his CO2 was way high, and then he started having chest pain. And I showed you, or I told you guys before, I don't have a chart for it right now, but as we go on into the class, you'll learn more about it. There'll be a waveform that comes out, and it comes to a cleft, and then it evens out and comes down. But if there's an obstruction or wheezing or anything, it'll look like a shark fin. And as much as I love sharks, shark fins are bad. So, that's why I love this. You can really tell if somebody, even if someone has fluid in their lungs, sometimes you can see that on the CO2 thing. So I am a huge fan of that. Nebulizer mask. Has anybody ever used a nebulizer mask before? My daughter has had to use them whenever she gets sick. So therefore, respiratory patients who need breathing treatments, and our next thing is pharmacology that we're getting into, so we'll really hit hard on that because you guys can give albuterol. But this is a nebulizer setup, and it comes with several pieces. It comes with this T-piece, a mouthpiece, then the medicine reservoir, the mask, and the tubing. So most people, if they're short of breath, I'm gonna give them the mask. If they can tolerate it, it's so much better to give the mask. So you get on scene, patient is short of breath, wheezing really bad, they have a history of asthma, or maybe they've got COPD, or ARDS. Has anybody heard of ARDS? ARDS. It's acute respiratory distress syndrome. So, basically, you're super short of breath, really sick, and it can be dangerous. But you listen to their lungs, you hear wheezing. Your partner says, "Hey, let's start a breathing treatment." So you pull out the package, you open it. This is the medicine reservoir. It opens like this. So you will get the albuterol, open the albuterol. It comes in like a little squeeze packet. You'll squeeze that in there. And then you will hook up something to remind you of how it works is, see the blue in here? And this is the blue end. You always stick the blue with the blue. And this part will hook to the oxygen tree or the oxygen tank. Now, if you choose to let them use the mask, which is what I recommend, all you have to do is pop that mask on there and it will aerosol out. We'll get into that probably next class. And again, make sure it's over their ears. They're gonna wanna talk during it. Tell them to take a deep breath, try to get all that medicine in. And eventually, what it does is it opens up the bronchioles. It's a bronchodilator, so it helps them breathe better. But if they cannot tolerate that, then you will put together, I'll put this together just out of habit. So it comes with these 3 pieces. For the first few times, if you don't put them together right, don't feel bad because you saw me even struggle sometimes to put it together right. But so you take this T-piece, see, and there's a smaller end on this T-piece, and we'll pass it around, let everybody see it. And you hook that together, and then you put the mouthpiece on. And then you hook it to this, and then they're gonna smoke it. I was telling like a peace pipe or whatever. And then they can go at their own pace. It doesn't work
as effectively as the mask, because with the mask, you're getting continuous, airflow, but with this, they cough, they put it down, they start talking to you, they start waving it around, and if they start waving around a whole lot, this medicine will come out and, it'll fling all over you and get in your eye, but, so, something to keep with, and I put down here, this is especially helpful for pediatric patients. Babies are not gonna tolerate something on their face like that, unless they have asthma and they're used to it, then the kids don't really mind that much. We actually used to have a telephone one that looked like a little telephone that they could hold by their mouth, and it would go, and I wish we still had those, but we don't. You can either have mom, which will probably be the most effective, or you put it by their face, so when you are aerosoling it, you can close this end with this hand. So this is hooked up to the oxygen, and so all of that nebulized medicine is coming out from right here. It's not coming out this side too. And you can just hold it by the baby, and if they're crying, you know that they're gonna be gasping, and so they will be getting that medicine. And mom can hold it. Parents are excellent tools to use in the back of the truck because the kid's more comfortable with them, and of course the mom, or I say mom, but dads too, I've had many dads do it too. They're always willing to help, so they're really a good source to go to. So the flow rate for this is 8 to 10. I always keep it at 8. That's just cause I know it is effective then. If you do it any less, they won't be getting the medicine as well. If you do it any more, it's like forcing air, and they'll get a very bad dry mouth. And something to be aware of, and again, we'll get into this in pharmacology, and you'll hear me say this a lot, it's called pant. If you're nebulizing a patient and they start to get agitated, it's because the most common side effects for albuterol are palpitations, anxiety, nausea, and tremors. So they'll feel like their skin is crawling and they're all amped up. And it's just a normal side effect of albuterol, so you just have to tell them, calm down. Plus they're already all jacked up because they can't breathe, so, they're nervy as it is. So sometimes it can be agitating, especially for the patient. But you just tell them, breathe through it, try to relax. Eventually, hopefully, this will work to open those bronchioles and get them working more. And if it doesn't, then there's other treatments that we'll go to next, mag sulfate, stuff that you guys won't have to worry about. But any questions on that? I'm gonna pass this around, and I'm also gonna pass this CO2 thing around because you guys are not as familiar with it. I don't know if we've actually even used this one. I know we did the others on the innovation and King too, but, and you can see that if you feel like it, you can put it on and see how annoying it is and why patients don't like it, but it really is my favorite tool, so I'm a huge advocate for it. So, the bag valve mask, I'm gonna walk up here just to check my time because I want to do it. The bag valve mask, you guys are pretty familiar with because we've gone over a bunch of stuff with it. But, so something to remember for bag valve masks is that, oh my gosh.
You never start.
No, it's just over 20 minutes then. So bag valve masks is for people who need assistance, whether it be too fast, too slow, or not at all. Some people that might need it are, of course, cardiac arrest patients. We've talked about that. So, what's the normal rate for adults with bag valve mask?
8 to 12.
Yeah.
Why do we say 8 to 12? Think back to your CPR stuff. What is the ratio of compressions to breaths?
32.
32, right. So, and then what about for pediatrics? What is it? You remember? 15 to 2, right. So you wanna make sure, and remember we talked about the, ETCO2 on that? You put, that's the one little tube thing that you stick on top of this. And it also in between there, and then, it can tell you, that's another reason why I love CO2, because you'll be in the middle of a code and you've got people yelling 50 different things. You've got one person who's recording, you've got someone who's working the monitor, you've got someone doing compressions, you've got someone on the airway, you've got bystanders talking, you've got law enforcement talking, someone's working on IV meds. So there's a lot going on. Can you really sit there and count seconds, or you just don't? So the monitor is amazing for that, because you can bag them, and it not only does it give a number on there, but it also will give you the range, and you wanna do between 35 and 45. There is one exception to that rule, and we'll talk about it at the end, and that's for a patient who has head trauma, and that's because you don't want to hyperventilate them and cause an increase in intracranial pressure. But we will talk about that when it comes. You ready? Anybody have any questions on this? Okay. So, extreme tachypnea. What does tachypnea mean?
Fast breathe.
Fast breathing, right. Remember, when it comes to heart and breathing, tachy is fast, brady is slow. So for neonates, which is newborns, basically, if they are breathing over 60 times a minute, or if pediatrics are breathing over 40 times a minute, and adults is usually around over 30, although I've seen some adults breathe at 30 that I would not bag for them. I mean, you kind of get your general impression, but if they're not effectively perfusing, you cannot perfuse when you're breathing that fast. But if they're not perfusing as well, you can kind of reset their breathing, and their body will kind of adjust with it. So you set the rate, and as you can assist them, so you see them start to breathe. Of course, you don't want to do it 30 times, but you bag with them. So when you bag, when they went over airway management, did they tell you the tidal volume to use? Do you guys remember? So tidal volume, the amount of stuff you want to put in here, is 500, which is like 3/4 of the 3/4, half of 3/4. I just bag like this. You don't want to do it too much, because then you're pushing all that air in their stomach, and then they get that gastric distension, and then I am gonna pop over there with that NG tube NG tube like we did the other day, like you saw me do, and you have to release some of that gastric distension. But, so you only wanna do about half to 3/4. You don't want to do it too fast, but you don't wanna do it too slow. You'll kinda get the rhythm. But look at that CO2, that's an excellent indicator. So, bradypnea. When do you think that might happen for bradypnea? Which is too slow, right? That's what we're talking about. What's a case that we see all the time, especially lately,
Moving drug.
overdose, right? That's when they're breathing, 2 times a minute, you show up on scene, people inevitably don't think they're breathing because it's either shallow, or if it's 2 times a minute, you don't really see that they're breathing. Or pediatrics, with pediatrics, most of the time, it's all gonna be a respiratory, not all, I would say 90% of the time, for pediatrics, if there's an issue, it's gonna be respiratory, unless they're born with some kind of congenital abnormality, but, and with neonates, it's respiratory too, but it's when they're first born, so we have to stimulate that breathing to where they get into the breathing, again. But, so if they're breathing on their own, you want to help them, and if they're breathing shallow, when they breathe, when you see their chest go up, squeeze that bag a little, make sure that you see that chest rise and fall. As far as, again, that golden number, I would beat it into your head, 35 to 45. I think each person has their own little thing that they, really look for, and mine is CO2. So, brain injury, people. You go to the scene of an accident and, let's say, or even fell like that. Sorry, buddy, but he did. After you log roll him, and we'll C-spine, all that good stuff, we're gonna act like I did that, and adjust his airway. You see that he is breathing, that chain Stokes breathing, kind of like a roller coaster, really, really fast, and really, really slow, and really, really fast, deep, shallow, no controlled rate of breathing. You look at his pupils, you see one pupil is dilated, one is constricted, he's probably got a head injury, right? So, if you hyperventilate this patient, it will increase that intracranial pressure, which is basically like swelling in the brain, and that's no good. So, we actually decrease ventilations for them. And the best way to do that is to keep the CO2 between 30 to 35. So that way you don't increase that intracranial pressure. Because really the only way to relieve that intracranial pressure is to pop a hole in his head. And we won't be doing that, despite what you see on television. Okay, what was that recent fire show? I watched. Yeah, Chicago Fire. She did it on. Yeah, and on Grey's Anatomy. Like, I love Grey's Anatomy, but some of that stuff, there's no way. Absolutely, no, I just like my job too much, I think. But so, anyways, they need a surgeon at a very higher level of care than we can give them. So you want to make sure to not hyperventilate them. So, how do we know that our treatments are working? You see the visible chest rise and fall, equal, right? Remember we did the assessment, we want to make sure that they're equal. Say you only see one side of that chest rising, what are you suspecting? Could be. Cause from what? What's the word? Do you remember the word for when they're, starts with an F? Flail chest, right. So if you don't see that, you can suspect that, and again, you guys won't decompress, but it could come down to decompression. But that's a good way to know, like when we worked with, last week with the mannequins, you want to see those lungs inflate, you'll see that chest rise, adequate SpO2 and CO2. Does anybody remember what the desired oxygen saturation is? What the range?
95 to 100.
Yeah, 95 to 99. So anything below 94, you want to give oxygen. An improvement of Pallor, which is what?
Color.
Color. And cap refill. How much is cap refill? How much do you want cap refill to be?
3 seconds.
Less than 2 seconds. So, that brings me to another point. Did you guys work on cap refill with Andy? Okay, so cap refill is when you push on the nail beds and you push down and you'll see, do it on yourself so you can see. You'll see the color blanch out of your nails. Now I can't because I've got S&S on there, and then you release. So the cap refill time is the amount of seconds it takes for that color to return, which is an excellent indicator of perfusion most of the time. There are things called Raynaud's phenomenon. Patients that have diabetes, they have really poor cap refill because the end of their fingers they have really bad circulation. And that's part of the neuropathy like we've talked about before and stuff. But, so there are some people, like for me, you could not assess my cap refill, but my nails are sparkling pretty. So what you could do is press on the palm of your hand, and it's not as easy to tell, but see how quickly, if you press down, it's kind of light, you release it, the color should return. And so you want less than 2 seconds. The longer that it takes, you know that they are not perfusing very well. And and everyone knows what I mean by perfusing, right? Okay, I just want to make sure. So you want to know that all of that stuff is going on. And if you see that, and of course there's going to be a better mental status, hopefully. And the numbers will be good. So we said 94 to 99. I mean, 100 is okay, but 99 is great. And it's very rare that you'll see it stay at 100 all the time. But in CO2, 35 to 45, unless a head injury, and if it's a head injury, it's what?
30 to 35.
30 to 35. See, I love you guys. You make me feel like I'm teaching you well. So, determining if there's something wrong. We talked about the Mohs thing last time, and I could not remember what the S is for, and then once I looked it up, I was like, duh, I totally remembered. But, so if you notice that there is not an increase in oxygen, the perfusion is bad, they still have horrible color, their lips are cyanotic, blue, gray looking, blue under their eyes, you know that something isn't going right. So you want to check to make sure that the oxygen is on, because believe it or not, that happens more than you would think. Sometimes oxygen tank will run out and you don't even notice. When you're bagging somebody on cardiac arrest and you're working that patient for 40, 45 minutes, you are going to go through a bottle of oxygen without fail every time. Because it's very rare that you have a completely full bottle of oxygen when you get there. But, so check the mechanics thing, follow the line, make sure it's hooked up. Make sure if you're on this, that this is aired up properly. If you're doing nebulizer, make sure it's aerosoling. And then the pore mask seal. Remember what we talked about with the C and the E? Making sure that you have a really good mask seal. And you want to see their cheeks puff up like this. Now, it's awesome to be able to do it this way like they have in the picture because there's 2 people, but that doesn't always happen. And improper positioning, like we talked about, remember with kids you have to extend them, you have to hyperextend them more because they have do not hyperextend them, I'm sorry, because they have large tongues, so you want to have them in that neutral position. But for him, you want to have him in that sniffing position. So remember earlier he was kind of cocky. So you want to make sure to position that airway so that way it's open. Well, try again, see if that works. And if that's on, is it an inadequate rate and volume? Are you only squeezing this bag like this? Because if you are, you're not giving him enough oxygen. Or are you squeezing too much? If you're doing this, you could have popped his lungs. I mean, that's just how it is. So just go over, recheck everything. That moments that I was talking about. So it's something that I always think of on every patient that I come to that's got a breathing issue at all, just because you could read in my head. So Moans is really for people who have the potential to have difficult airways. So mask seal, if someone has a big beard, it would be more difficult to get a mask seal on you than it would on Andrew, right? Because you've got a beard. Also, facial piercings, there's a lot of that these days. So maybe that's getting in the way. Maybe they have like a big old thing. Maybe they have a big wad of chew in there. I don't know. You're not getting a good mask seal. So make sure that you're getting that. Or if you don't have the right size, if you're using a pediatric face mask, it's not gonna fit properly. Sorry. Obstruction or obesity. Obstruction, of course, if you think maybe you're choking on a piece of steak, you can look down in there. You guys went over that with CPR, right? You don't ever do blind finger sweeps. But look at it, if something's not working, look in there. It could be an obstruction. It could just be, like we're talking about, that they need to be suctioned. Or the obesity, it's an epidemic. I have a much more difficult airway than Veronica does, just because I am bigger, so you might have to adjust more, or maybe even put a rolled towel under their neck, so that way it opens that airway more. You could try that. No neck, that's the same. If they have a very short neck, chances are you're probably gonna have difficulty with that. So you can gauge that and kind of prepare for that. When you can walk up to that patient and say, hey, this patient's 800 pounds, you know, it's probably gonna be a difficult airway. And stiff lungs, that's what the S is for that I could not remember. COPD, asthma, I had the word for it, where they have too much mucus in their lungs. There's a really good book about it. Cystic fibrosis, that's it. They have stiff lungs, so they don't have a lot of compliance. So if you're trying to bag them and their chest isn't rising very much, it could be from stiff lungs. So, intubation. Choosing the right supplemental oxygen administration route is very important. Remember your ABCs. A, airway. And if it doesn't work, try something else. I'm not saying, tell your partner to cry gun if you can't get a good mask seal, but you definitely want to get that airway, and especially for pediatrics, that's like the very most important thing. Any questions? All right, where are we at for time? That's good. Can you push stop for me? Thank you. It did the whole thing. Pretty excited. All right, let's take a break, because I'm so over talking.